Hello students, so I'm Dr. Swati and I'm here to support you for your focused last lap of anesthesiology. So NEET PG is approaching. So for anesthesiology, what are the important things that we have to focus on? What are the important topics that we have to focus on? In this video, what I will discuss with you, I will discuss with you the important topics and the related question. So let us run the last lap of anesthesiology together. I have divided my lecture in three important parts. What I see for the questions of anesthesiology, there are three important type of questions asked in anesthesiology. One are the questions which are pharma-based, drug-based. Second are the image-based question, and third is the clinical question. So for most of the topics, I have divided it like that only: pharmacological questions, image-based question, and clinical question. And Sagar, Hitesh, good evening. So can we start? Can we start with the kind of questions which I expect which can be asked in your NEET? So let us start. Let us start with pharmacological part. In pharma part of anesthesia, what I expect questions can be asked from the important drugs of general anesthesia, which comprises of inhalational anesthetics, intravenous anesthetics, and neuromuscular blocker. So let us first focus what questions can be asked on inhalational hypnotics. The first thing which can be asked, what exactly is inhalational hypnotics? The name of the drugs. So we have to be familiar with the name of the drugs which comes under inhalational hypnotics. So what are the drugs which comes under inhalational hypnotics? We have halothane, intravenous anesthetics, and neuromuscular blocker. Halothane. So let us first focus your isoflurane, your sevoflurane, your desflurane, right? These are the four important inhalational hypnotics which we are using for producing loss of consciousness, right? Okay. Now, the most important thing in these inhalational hypnotics after their nomenclature, what can be asked is about their potency. Now, last NEET also, I saw an important question on potency. So you have to remember that potency is described by the MAC of the agents. And what you have to remember is that less MAC, high potency, right? Less MAC, high potency. So agent which would have less minimum alveolar concentration required would have high potency. And you have to know the agent from most potent to least potent, right? You have to know the sequence. So remember, you have to remember extreme two ends, the most potent and the least potent. Most potent overall, most potent is your methoxyflurane. Another is inhalational hypnotics, which is not in clinical use. So methoxyflurane. Okay, this is most potent. Okay, the least potent is our nitrous oxide. Okay, which cannot be used as single anesthetic agent. And in between the most potent and the least potent is your halothane, H for halothane, I for iso, S for sevo, and D for desflurane. So the sequence in which they came in clinical practice: halothane, then your isoflurane, then your sevoflurane, then your desflurane, and then nitrous oxide. So this is an important sequence that you have to remember: the most potent to least potent, because their MAC increases in this sequence and their potency decreases in this sequence. So remember, MAC is increasing and the potency is decreasing. Got it? So remember the sequence. The sequence is important. The second thing which can be asked about inhalational anesthetic agent after potency is the speed. Well, remember, the speed depends upon the blood gas partition coefficient. MAC depends upon what? Potency depends upon what? MAC, right? So potency depends upon MAC. And the speed depends upon blood gas partition coefficient. Okay? Less the blood gas partition coefficient, Less soluble in blood, less blood solubility, higher is the speed, faster is the speed, right? So remember, the least blood gas solubility is of desflurane, right? The latest agent, it has least blood gas solubility, so it is fastest. Then the sequence, sevoflurane, then isoflurane, and then halothane. And again, I will put the nitrous oxide and another carrier gas, that is xenon, in this sequence. Remember, xenon has lowest blood gas solubility. It is fastest. The blood gas solubility of xenon is 0.11. Desflurane 0.42. Sevoflurane 0.63. Isoflurane 1.2. And your halothane 2.25. So as the blood solubility is increasing, speed is decreasing, right? So xenon is fastest, then desflurane, then sevo, then iso, and then halothane. Remember this, okay? The sequence is important again. So for potency, we discuss the sequence, and for the speed, we discuss the sequence, okay? This is important for inhalational. Then another important thing for inhalational, which I think can be asked in the question about the pharmacokinetic of inhalational. I have picked up one question. Which inhalational anesthetic agent has the lowest, lowest solubility, which inhalational anesthetic agent is has lowest boiling point? You know, these inhalational hypnotics which I'm talking about, that is your halothane, your isoflurane, your sevoflurane, your desflurane, they are liquid at room temperature. They are liquid at room temperature, right? And most of them have same, the boiling point. Their liquid has same boiling point. Only the boiling point of desflurane is least. So least boiling point, desflurane. And since it has least boiling point, desflurane, right? Desflurane requires special vaporizing principle. So desflurane has least boiling point, and desflurane has highest vapor pressure. Highest vapor pressure. So desflurane is unique. Least boiling point, highest vapor pressure. And because of these two, it requires special vaporizer. Special vaporizer, right? So this is again a potential exam question which I think can be asked. Recently, they have focused a lot on that which inhalational agent requires a special vaporizer. So desflurane requires a special vaporizer. Remember it. Now about pharmacodynamic, what are the things which can be asked about inhalational agents pharmacodynamic? Remember, inhalational anesthetics pharmacodynamic, they can ask about the peculiar things about them, right? Remember that halothane, I will just tell you a few peculiar things about all the 4 inhalational agent: halothane, isoflurane, sevoflurane, and desflurane. Okay. Halothane can cause hepatitis. It is hepatotoxic. Halothane is most cardiovascular unstable. Okay. Desflurane is most cardiovascular stable. Okay. Remember this. So desflurane is most cardiovascular stable. Sevoflurane, it has good smell, right? It has good smell. So this is, sevoflurane is inhalational agent of choice for your induction. So any question asked, which inhalational anesthetic agent can be used solely alone for induction and for intubation? The answer becomes sevoflurane. So sevo can be alone used for induction and intubation. Sevoflurane. Desflurane is most cardiovascular stable. So desflurane, for any patient with cardiovascular instability, among inhalational, des would be best agent, right? Halothane is most cardiovascular unstable and it can cause hepatitis, right? And isoflurane is good agent, good for CNS also, and good for your cardiovascular system also. Okay, iso and sevoflurane more or less is same, right? But since desflurane requires a special vaporizer, it is less commonly used and it is a bit costly also. So isoflurane is more common in clinical use, but desflurane and isoflurane is more or less same. In fact, desflurane is the structural analog of isoflurane. So remember this, okay, for inhalational. Now coming on intravenous, again, what question can be asked? Question can be asked on classification. Intravenous anesthetic agent can be classified into your opioid and non-opioid. Non-opioid, okay? So for opioid, you have morphine. It can be used as inhalational intravenous anesthetic or intravenous hypnotics. Okay. Morphine, fentanyl, okay. Remifentanil, your alfentanil, and your sufentanil, right? So these are the opioids which can be used as sole IV anesthetic agent. And non-opioid, very important, thiopentone, then propofol, then etomidate, and then your ketamine. These are 4 important non-opioid IV anesthetic agent. Got my point, everyone? Okay. So what first thing which can be asked in exam? Their classification. So these are opioid and these are non-opioid. Very popular question. Which is non-opioid IV anesthetic agent? So these are non-opioid. Which are opioid? These can be only used as IV anesthetic agent and they are opioid. So which are opioid, which are non-opioid should be clear concept. Then the next question which can be asked, indication. Remember, for opioid, we are not using them as routine IV anesthetic agent. What is the use of opioid in anesthesia? Mostly for analgesia. So where we are using opioid for anesthesia? Remember, only in severe cardiovascular compromise. Severe cardiovascular compromise. Why? Because they are cardiovascular stable. They are completely cardiovascular stable. Okay. Non-opioids, cardiovascular unstable. Most of them unstable. One agent stable, and I will talk about it. Okay. So 2 things we have to know about them for solving question, their indication and their side effects. So let us talk about thiopentone, propofol, etomidate, ketamine. Okay. So your thiopentone indication for anesthesia, nowhere agent of choice. 2 non-anesthetic use. It is agent of choice for narcoanalysis and for neuroprotection. Remember, right? So thiopentone has 2 important uses, narcoanalysis and neuroprotection. Now propofol, where it is agent of choice, I will just tell you in a second. Etomidate. I want to share a star point of etomidate. This is non-opioid IV anesthetic agent, but completely cardiovascular stable. So it is completely cardiovascular stable. Okay, etomidate is completely cardiovascular stable. So it is anesthetic agent of choice in cardiovascular compromised patient. Cardiovascular compromised patient. Okay, so it is agent of choice in cardiovascular compromised patient. Ketamine, it is anesthetic agent of choice in shock. Why? Because it is sympathomimetic drug. It is sympathomimetic. It will increase the blood pressure and heart rate. And it is agent of choice in bronchial asthma. Why? It is best bronchodilator. So what are the question asked? Which is IV anesthetic agent of choice in shock? Answer is ketamine. IV anesthetic agent of choice in bronchial asthma? Answer is ketamine. IV anesthetic agent of choice in cardiovascular compromised patient? Answer is etomidate. Right? Thiopentone, nowhere IV anesthetic agent of choice. 2 non-anesthetic use, narcoanalysis, neuroprotection. And for anything else, they ask IV anesthetic agent of choice, answer is propofol. So for daycare surgery, for neurosurgery, for thoracic surgery, you're getting my point? For any surgery, right? For endoscopy, for porphyria patient, right? For all, IV anesthetic agent of choice is propofol. Got my point? Okay, so this is how you have to remember the clinical questions for where IV anesthetic agent of choice. Okay. Now thiopentone. What is the problem with thiopentone? Thiopentone is cardiovascular unstable. It is cardiovascular vascular, unstable. Thiopentone is bronchospastic. Bronchospastic. Thiopentone is anti-analgesic. Anti-analgesic. So 3 important problem of thiopentone. Cardiovascular unstable, bronchospastic, anti-analgesic. Propofol, 2 important problem. Cardiovascular unstable and pain on injection. Pain on injection. Whenever we inject, wherever we inject, there is a local pain. Etomidate, question. Etomidate, completely cardiovascular stable agent, right? Etomidate is completely cardiovascular stable, but etomidate is not so commonly used. Why? Because it causes adrenal gland suppression. Adrenal gland suppression. It causes suppression of the adrenal gland. It can cause myoclonus, right? 2 important side effects of etomidate. And it can also cause pain on injection. Pain on injection, right? Ketamine, very important side effect, emergence delirium. Emergence delirium. Okay. So ketamine can cause emergence delirium. Understood this? So these are the important side effects of these 4 agents that we have to remember. Very, very, let's say, probable question for your NEET. Okay. So emergence delirium. So this is about our IV. Now coming on neuromuscular blocker. Most expected question on neuromuscular blocker, mode of action. Well, remember, neuromuscular blocker is divided into 2 broad groups, depolarizing and non-depolarizing, right? Non-depolarizing. Now remember, for depolarizing, the only example is succinylcholine. And succinylcholine, what is the mode of action of succinylcholine? The mode of action is persistent depolarization of postsynaptic neuromuscular junction, right? So persistent depolarization of muscle end plate, right? So neuromuscular junction, the muscle end plate, persistent depolarization. And what is the mode of action of rest all except succinylcholine? Competitive antagonism. So non-depolarizing competitive antagonism of acetylcholine. These are competitive antagonist. Remember. So rest all competitive antagonist and succinylcholine persistent depolarization of muscle end plate. Remember this point. So this is their mode of action, right? At neuromuscular junction. So neuromuscular blocker act at neuromuscular junction by 2 mechanisms. They are divided into depolarizing, non-depolarizing. Depolarizing succinylcholine, mode of action, persistent depolarization of muscle end plate. Non-depolarizing competitive antagonist. Got my point? Okay. Now what we have to know about them? The neuromuscular blockers. The one neuromuscular blocker which I expect can be asked in exam is atracurium. What can be asked about atracurium? So I have written it separately. It is a non-depolarizing neuromuscular blocker, atracurium. Its metabolism is unique. And its metabolism is so many times asked in exam. It is metabolized by Hoffman degradation. Hoffman degradation, which is non-enzymatic time-bound self-destruction of the drug. Non-enzymatic time-bound self-destruction of drug. Got it? And by this Hoffman degradation, it is agent of choice for your renal, hepatic dysfunction. So atracurium, and of course, its isomer, cis-atracurium, both cis-atracurium. They are metabolized by Hoffman degradation and they are agent of choice, the neuromuscular blocker of choice in kidney and liver dysfunction. So kidney and liver dysfunction, an expected question of exam. Okay, these 2 are agent of choice, atra and cis-atra. And if an exam, both are asked, both are there in the option for kidney and liver dysfunction, agent of choice they have asked, always cis-atracurium. Cis-atracurium is better atracurium. Better atracurium. So cis-atracurium is better atracurium. Remember this. Okay. Cis-atra is a pure cis isomer. It's a better atracurium. Okay. So this is about the drugs of general anesthesia. Now, drug of regional is local anesthetic. Local anesthetic is drug of regional anesthesia. Okay. And in local anesthetic, what is the mode of action? Very popular question of local anesthetic. It binds to the sodium channel present on the nerve membrane. So it binds to sodium channel, right? On nerve membrane. Remember, this is so many times asked, but what I expect has been asked also. What I expect again can be asked. It can bind to the sodium channel. How? It blocks the sodium channel in what state? Remember, it binds to the sodium channel in closed and inactive state. Closed and inactive state. So it binds to the sodium channel in closed and inactive state. Okay. Now, local anesthetic can be classified into ester and amide, two groups. And I want you people to remember only three drugs. In ester, one drug, that is cocaine. Cocaine is a very popular LA, which is so commonly asked in exam. I want you to remember 3 points of cocaine, which is asked in exam. First, it is natural LA. It is natural local anesthetic, right? It is natural LA. All other are your artificial LA. Your cocaine is the natural local anesthetic. Got my point? Okay. Then remember, cocaine is a vasoconstrictor. What to repeat, Anurag? Tell me, what is the point you haven't understood? You will have the recorded session also available on YouTube. So cocaine is the natural local anesthetic. And remember, cocaine is a vasoconstrictor. Vasoconstrictor. So this is the only LA which is vasoconstrictor. It can cause hypertension. This has been asked in last NEET. Which local anesthetic can cause hypertension? Cocaine. Cocaine is a special LA, which is a vasoconstrictor, which is a natural LA. And this is the only ester which is metabolized by liver. Liver metabolism. Right? 3 important points of cocaine. In amide, just remember 2 LA. Lignocaine. What I want you to remember about lignocaine? Safest LA. Safest LA. And the second, I want you to remember bupivacaine. What I want you to remember about bupivacaine? Most cardiotoxic. Most cardiotoxic. So bupivacaine is most cardiotoxic. Remember this, okay? So bupivacaine, most cardiotoxic. Lignocaine, safest LA. Cocaine, a natural LA, vasoconstrictor, liver metabolism, can cause hypertension. All are potential exam questions. All are potential exam questions. And most important potential exam question of local anesthetic. Local anesthetic systemic toxicity. Remember, guys, local anesthetic systemic toxicity, or we popularly call it LAST. How do I put local anesthetic? We use it for regional anesthesia, deposit it locally. If it gets systemically absorbed, we call it systemic absorption, and it will cause toxicity because it will bind to the sodium channel of cardiovascular system and sodium channel of your central nervous system, and it will cause CVS and CNS toxicity, right? Guys, CVS and CNS toxicity of local anesthetic. And when local anesthetic causes CVS toxicity, it can also result in cardiac arrest. Remember, it can cause cardiac arrest. Management. Very important point. Management of LAST. For management of LAST, you have to remember one very important drug. 20% intralipid emulsion. Intralipid emulsion. 20% intralipid emulsion is antidote for LAST. It absorbs local anesthetic from systemic circulation and take it away and not let it bind to the sodium channel of CNS and CVS. 20% intralipid emulsion. Got my point? Okay. So how do I manage LAST? We manage it symptomatically, and by giving 20% intralipid emulsion. So whenever we give it with 12, what happens? 20% intralipid emulsion absorbs local anesthetic and remove it from systemic circulation. So this is the most important point, which I expect can be asked in exam. Any question on LAST? What is the management? 20% intralipid emulsion. That would be the right option. Got it? So this is about the drugs. Now let us talk about some image-based question. All right. Now, in airway, I expect image-based question. In airway, I expect questions on basic airway maneuver and basic airway adjunct. Now, these are the maneuver and the devices to open an obstructed airway. So these only makes the airway unobstructed. Okay. And advanced airway device, they open the airway and can also be used for ventilation. So advanced airway device can also be used for ventilation. Got my point? Basic airway device is only used to make the airway unobstructed. Your airway is that part of your respiratory tract which takes the atmospheric air, which leads the atmospheric air to alveoli. If obstruction will happen, then your atmospheric air will not reach the alveoli and hypoxia will happen. So how do I remove the obstruction? By basic airway maneuver and airway adjunct. And when I have to make the airway unobstructed and also have to give gases and ventilate, we put advanced airway devices. Okay, so now just few very important images. For airway maneuvers, two important basic airway maneuvers: head tilt, chin lift, and jaw thrust. So what are the things which can be asked in exam and has been asked in exam? First, image-based question. They can give the image and they can ask you to recognize it. So head tilt, chin lift. With one hand, head is tilted backward, and with other hand, chin is lifted forward or upward. Now this maneuver opens the airway. It opens the airway, right? It opens airway, removes the tongue from falling on the airway. Okay. But this maneuver involves the movement of cervical joint. So in trauma patient, we want to do jaw thrust. Jaw thrust with both hands, we are keeping the head and neck joint in a neutral position, and we protrude the mandible forward. So this creates an unobstruction, right? And this is the maneuver of choice in trauma patient. So in trauma patient, this is the maneuver of choice, jaw thrust. And in non-trauma patient, which is the maneuver of choice? Head tilt, chin lift. So two very important maneuvers. Then these are the two very important basic airway devices. First one is oropharyngeal airway. Right? What are the questions which can be asked? Image to recognize the device. So you are seeing the device on the screen. It is your let's say oropharyngeal airway. Second question which can be asked: how do you put it? To put it, the first thing we do, we choose the correct size. How do we choose the correct size? By measuring from angle of mouth to angle of mandible. Angle of mouth to angle of mandible. So from angle of mouth to angle of mandible, we have to measure it, right? And in the problem of this device, it is made up of plastic. So it is not used in conscious patient. Not used in conscious patient. Okay, not used in conscious patient. So which is the device we use in conscious patient? This nasopharyngeal airway. Nasopharyngeal airway. Okay. So nasopharyngeal airway is inserted from nose and it lies in the oropharynx with the tip just above the glottic opening. Creates a passage for the air to pass. So this is a very good device. Can be used comfortably in conscious patient. Comfortably in conscious patient. Conscious patient. How do I insert it? By measuring from tip or ala of the nose to ear lobule. Tip or ala of the nose to ear lobule. So we measure it from tip to the ear lobule. Tip of nose to ear lobule. That would be the correct size. Tip of nose to ear lobule. This should be the correct size for that individual. And what about oropharyngeal airway? From angle of mouth to angle of mandible. Got my point, everyone? Keep it in mind. Okay. So these are the important devices. Conscious patient, nasopharyngeal airway. Unconscious patient, oropharyngeal airway. Then this is our advanced airway device, endotracheal tube. Endotracheal tube. So what are the questions which can be asked from endotracheal tube? Well, I have given you the label diagram. All the things which are part of endotracheal tube: B well, Murphy's eye, cuff, vocal cord guide, this black markings, and the universal connector. This is the universal connector. What question I expect? That how is the sizing of the tube done? Well, because I'm seeing a lot of questions being asked on the sizing. How is the sizing done? The tube is sized on internal diameter. Tube is sized on internal diameter, right? So we have different sizes of tube based on its internal diameter. Adult male 7.5 mm internal diameter. Adult female, right, 7 mm internal diameter. So internal diameter, pediatrics 3-4 mm internal diameter. So this internal diameter is how the tube is sized, and this internal diameter is always written on the tube. Got it? The next question which can be asked, special type of tubes. So 3 important special tubes I want you people to remember, but before that I want to show you the image of the device which is used for inserting the tube. This endotracheal tube can be inserted from oral cavity, orotracheal intubation with the help of this device. This is laryngoscope. If the laryngoscope is a device which is used to insert the tube, if the laryngoscope has curved blade, this is Macintosh. This is the common one used in adult. Okay. And this is the straight blade. This is Miller's laryngoscope. Okay, Miller laryngoscope, right? So this is used more commonly in pediatric. So 2 important image of laryngoscope which is used for putting the tube through oral cavity, Macintosh laryngoscope and Miller laryngoscope. Straight blade laryngoscope, curved blade laryngoscope. Got my point? Okay. Then some special tubes. 3 important tubes I want you to show. First one, this is flexometallic. What is special about flexometallic tube? Its inner diameter is reinforced by a metallic wire. So this has become kink resistant. So any tube with a metallic wire, it is flexometallic tube. Okay. Then this is our double lumen tube. Okay. They can give you the image of double lumen tube. It has 2 lumen. One lumen will be of blue color and other would be the transparent lumen. One lumen will end in trachea and other lumen will go into one of the bronchus. So this is double lumen tube. This is used for one lung ventilation. Got it? Okay. And then this is uncuffed tube. Uncuffed tube. You can see there is no cuff. These tube have cuff, but this has no cuff. This is used in pediatric patient. Okay. So this is used in pediatric patient. Got my point? Okay. So uncuffed tube is used in pediatric patient. Okay. Got my point? Okay. Now next point of the tubes. Image can be asked, then they can ask that which tube is used for what type of surgery. So remember, flexometallic tube is used for neurosurgery. It is used for head and neck surgery, right? And for dental surgery. Double lumen tube is used for thoracic surgery. And uncuffed tube is used for pediatric patient for any kind of surgery. Right? For any kind of surgery. Uncuffed tube is used for any kind of surgery. Got my point, everyone? Okay. So next point. Another advanced airway device. This is your supraglottic airway device. I would show you there is an image of 2 supraglottic airway device. This is LMA classic, laryngeal mask airway, or we call it LMA classic, right? And this is LMA ProSeal. So first question which can be asked, image. LMA classic has single tube. This is first generation supraglottic airway device, first generation. Only used for ventilation. Only for ventilation. And this is second generation LMA ProSeal, second generation. It is used for ventilation and it is comparable to ET tube in preventing aspiration. So ventilation and comparable to ET tube for preventing aspiration. Preventing aspiration, right? So it has two uses, prevention of aspiration and for ventilation. But still, guys, the best airway device still to prevent aspiration is your endotracheal tube. The best airway device to prevent aspiration is endotracheal tube. Got my point? Okay. Then this is another second generation supraglottic airway device, which I think an image-based question can be asked. Second generation supraglottic device. What is this? Anyone can recognize it? Anyone can recognize this device? What is this device? Anyone? You can put it in the chat box. Right? So what is this? This is iGel airway. iGel airway. Okay, this is iGel airway. Got my point? This is iGel airway. Okay, this is iGel airway. Understood? Okay. Then next important thing I want to discuss with you is devices of oxygen therapy. Devices of oxygen therapy. Devices of oxygen therapy. Right? Oxygen therapy. Okay. Now, devices of oxygen therapy is divided into two important parts. That is low flow and the high flow devices. Low flow and high flow devices. Now, these three images, keep it in mind. These are low flow devices. Low flow, or we call it conventional devices. Conventional oxygen therapy device. Therapy device. In this, you have to recognize three. This is nasal cannula. This is nasal cannula. Nasal cannula. Right? This is nasal cannula. This is face mask. Face mask. Okay? And simple face mask. This is simple face mask. And this is your face mask with reservoir bag. Reservoir bag. Or we call it NRM, non-rebreathing mask. You can see there's a face mask and there's a bag, non-rebreathing mask. So what is the thing you have to remember about these three devices? We have to remember about these three devices. We have to remember the flow rate. What is the oxygen flow rate we have to keep? And we have to know about the FiO2. So remember, for nasal cannula, 2 to 6 liter, not 4, 2 to 6 liter per minute, we can keep the flow rate. For face mask, 6 to 10 liter per minute. And for NRM, we can keep 10 to 15 liter per minute, the flow rate. And the next thing we have to know is about the FiO2 they can give. Your nasal cannula can give from 0.23 to 0.45. Your simple face mask from 0.33 to 0.60, that is 33 to 60%. And your NRM, non-rebreathing mask, from 0.7 to 0.9, that is, it can give 90% of oxygen. So these are the potential question. These are the potential question. Got my point, everyone? Okay. These are low flow devices, conventional oxygen therapy, which cannot give more than 15 liter per minute of oxygen. Okay. Now, high flow device. This is the first high flow device. Very important from exam, the image. This is Venturi mask. Venturi mask. You can distinguish the difference between a simple face mask and Venturi mask. Venturi mask has a Venturi barrel. This is Venturi barrel, right? This is called Venturi barrel. Okay, this is the Venturi barrel. Okay. Now, oxygen goes into this Venturi barrel and give patient, and patient receive flow of very high, because this Venturi barrel entrains the room air. It can suck in the room air. So it sucks the room air along with the oxygen which we supply. So patient gets a very high flow. So this is a high flow device. So remember, it is color coded. These are Venturi barrels And on every barrel, the flow and the FiO2 which it will give is written. Remember, they give fixed FiO2. They give fixed FiO2, and this is independent of the patient's breathing pattern, which was asked in last exam of FMG, that which device give oxygen concentration independent of the patient's breathing pattern. High flow, fixed FiO2 devices. Low flow devices, their FiO2 depends upon the breathing pattern of the patient. They do not give fixed FiO2. Their FiO2 is variable. High flow devices gives fixed FiO2. So they give FiO2 independent of patient's breathing pattern. I expect this question in NEET, right? This was asked in your FMG. This question can be asked in NEET. It's a very good question, actually. So independent of the patient's breathing pattern. Now, very important, two important oxygen delivering device. This is HFNC, high flow nasal cannula. High flow nasal cannula, HFNC. And this is a BiPAP machine. BiPAP machine. What is the difference? Both look same. Both have a device. What is the difference? The patient's interface. Here, the nasal cannula is the patient interface. Here, the mask is the patient interface. So for BiPAP machine, it is the mask which is the patient's interface. And here, the nasal cannula attached to this machine. This machine is a machine which has a blender. This is a blending system, blender. It has a blender. So these are the blender which mix oxygen and air according to the FiO2 we want to deliver. So high flow devices are mostly based on blending system, except this Venturi mask, which is a special high flow device, but it is a high flow device. Okay. Other high flow devices mostly based on blending system. So these are based on blending system. So image, very important for these high flow devices. Okay. Now, next topic, ventilator setting. They can ask question on ventilator setting. Two kind of question I can expect. They can tell you a patient is on ventilator, and they can give you ABG, and they can ask what change you will do. Now see, if you see this ABG, the first question, ABG, patient has PaO2 of 54, which is less, PaCO2 normal, SaO2, because PaO2 is less, it is less. So what is the problem here? What is the problem? Problem is oxygenation. Oxygenation is not proper, right? Here in the next patient is on ventilator and pH is less. Patient is going towards acidosis. PaO2 is okay. PCO2 is less. pH is less. PCO2 is less. And saturation is okay. PCO2 is more, not less. It is 62 mm of Hg. It is more. I mean, respiratory acidosis, right? Here, what is the problem? First question, PaO2 was less. Second question, PaCO2 is more. So in first question, oxygenation was problem. In second question, the problem is ventilation. Ventilation. So guys, if any such question comes, how to change the ventilator setting? So for oxygenation, to improve oxygenation, what things we can increase? We can increase FiO2, fractional inspiratory oxygen concentration. And we can increase PEEP, positive end expiratory pressure. PEEP opens the alveoli, improves the exchange of oxygen and carbon dioxide. So oxygenation improves. FiO2 gives increased concentration of oxygen. So oxygenation improves. And if we have to improve the ventilation, so what we have to increase the minute ventilation. We have to increase the minute ventilation. So how do I increase the minute ventilation? By increasing the respiratory rate and by increasing the tidal volume. So any question, what changes we will do would depend upon how the patient's ABG is. If patients in ABG of the patient, oxygenation is a problem, we increase FiO2 and PEEP. And if ventilation is problem, we increase the minute ventilation, that is respiratory rate and tidal volume. So this is very important. Keep it in mind. Okay. Then the next question, which can be asked on cylinders, they can ask questions on the color coding of the cylinder. 4 important cylinder I have picked up for you, which can be asked. Oxygen, black body is black, shoulder is white. Nitrous oxide, the entire cylinder is blue. And carbon dioxide, which is gray. air, I am writing, it is not in the image. Gray body, black and white shoulder. Gray body, black and white shoulder. Gray body, black and white shoulder, remember. And this is of helium, a new gas. Helium, that is heliox. Helium plus oxygen. It is used for oxygen delivery. Okay. So we have air, gray body, black and white shoulder. Carbon dioxide, total gray. Nitrous oxide, total blue. And oxygen, black body, white shoulder. Black body, white shoulder. So color coding of the cylinder important. Most important, oxygen. Most commonly asked, oxygen. Okay. Then they can ask pin indexes. Pin index. This is a system which prevent incorrect attachment of cylinder to machine. So how to remember it? You see, there are 6 pins. We have around in the port of the cylinder, there is an opening of the cylinder from which the gas will go into the machine. Around it, there are 1, 2, 3, 4, 5, 6 positions where the holes are present and the corresponding pins are on the machine where the cylinder will attach. Okay. And every gas has been given a pair of position, right? The pair has been assigned in 2 ways. 1, 5, 2, 5, 3, 5. This is 5 system. 1, 6, 2, 6, 3, 6. This is 6 system. Now 1, 5, 2, 5, 3, 5. Nitrous oxide has 3 atoms, 2 nitrogen, 1 oxygen, 3, 5. Oxygen, O2, 2, 5. Air is a mixture, 1, 5. Okay. And all the gases which starts with C is in 6 system. Carbon dioxide, 1, 6, 2, 6. It is 2 pin indexes. It has 1, 6, 2, 6. If more than 7% concentration, 1, 6, less than 7%, 2, 6. And cyclopropane, another gas which has 3, 6. So keep it in mind. Then next thing which can be asked in machine is about the pipeline supply. So you can see this kind of image can be given. An arrow can be put on any pipeline and they can ask you that which gas is transported by this pipeline. So 4 colors of pipeline you will see in your OTs. Your black, your blue, your white, and your yellow. Now, yellow is not for any gas, it is vacuum. Vacuum. White is for oxygen, blue is for nitrous oxide, and black is for air. These 3 gases are supplied through pipeline. So these 3 gases are supplied through pipeline. Got my point, everyone? Okay. So pipeline, any arrow on any pipeline, and they can ask which gas is being transported through this pipeline, right? So gases are supplied from machine either through pipeline or from cylinder. Cylinder color we discussed and the pipeline color we discussed. Both are important from exam point of view, simplest question. Then the next question, which can be clinical question, which can be asked on central neuraxial blockade. Central neuraxial blockade, spinal and your epidural, spinal anesthesia and epidural. They can ask the layers pierced for giving spinal, layers pierced to give epidural. I mean, one of the most common expected question. For spinal anesthesia, you can see the first layer pierced is skin, then your subcutaneous fossa. So first is skin, then subcutaneous fossa, right? Then your supraspinous ligament. These are the supraspinous ligament. Then interspinous ligament, which is between the 2 spinous process. Then your ligamentum flavum, right? Then your dura mater, and when you pierce the dura mater, you enter subdural, and then arachnoid mater, and then you enter the subarachnoid space. This is subarachnoid space. So last layer to pierce to reach the subarachnoid space is arachnoid mater. We pierce the arachnoid mater and we get a return of CSF. Return of CSF, right? By this return of CSF, we know we are in subarachnoid space. And for epidural, we have to just stop outside the dura mater. So we don't have to pierce the dura mater. We just, last layer is ligamentum flavum. Ligamentum flavum, right? So this is expected question. Ligamentum flavum we pierce, we enter epidural space. Now there is a special epidural that is called caudal. Caudal is sacral epidural. Now in sacral space, the ligamentum flavum is modified into sacrococcygeal ligament. So to enter the caudal space, we pierce sacrococcygeal ligament. Sacrococcygeal ligament. So this is the last layer to pierce to reach the caudal space, sacrococcygenial ligament. Okay. And remember, cisternae is dilated subarachnoid space. Cisternae means dilated subarachnoid space. So when you enter any cisternae, you enter subarachnoid space. So what is the last layer to pierce to enter cisternae? Arachnoid matter. Keep it in mind. Okay. So this is important for central neuraxial blockade. Then in pre-anesthetic evaluation, they can ask the Mallampati grading. This is image of Mallampati grading. Mallampati grading is your pre-anesthetic evaluation for predicting difficulty in intubation. Difficulty in intubation. As you can see, we ask the patient to open the mouth and then see the structures of oral cavity. All the structures seen, the tongue is small. And if structures are obscure, tongue is becoming bigger. So from 1 to 4, the tongue is becoming larger and the intubation is becoming difficult. So what is Mallampati grading? Grading, what does it grades? Size of tongue. Size of tongue. And if tongue is big, it is difficult to intubate. So difficulty in intubation. It is pre-anesthetic evaluation. Got my point? Okay. Then guys, next thing which can be asked in pre-anesthetic evaluation, NPO order. Very important. NPO, very commonly being asked, nil per oral. So I have made adult and pediatric nil per oral together. You have to remember the 4 timelines. 2, 4, 6, 8. 2 hours NPO for any clear fluid. Clear fluid. 4 hours NPO for breast milk. Children on breast milk, we keep 4 hour NPO. Last breastfeed 4 hours prior. Adult or children, right? Any light meal, 6 hours. Light meal, 6 hours. And children on any other formula feed, 6 hours. Formula feed, any feed, lactogen, anything, 6 hours. And 8 hours for heavy meal. Heavy meal. Got it? Okay. So remember this. NPO, what we ask the patient today, to take a light meal 6 hours prior to surgery. If breast feed is mentioned, then 4 hours NPO. Clear fluid mentioned, 2 hours NPO. And if heavy meal mentioned, 8 hours NPO. Otherwise, NPO means, remember, is 6 hours NPO what we require. Nil per oral. Important from exam point of view. And every patient undergoing elective procedure, general or regional anesthesia, requires to follow NPO guideline. Got it? Okay. Next. Anesthesia monitoring. Remember, all the monitor, this is the master screen of a monitor. This is the master screen. And whatever I have shown on the master screen, they are mandatory monitors. That is ECG, a mandatory monitor. Your oxygen saturation, a mandatory monitor. That is pulse oximetry. Your ETCO2, a mandatory monitor. Your blood pressure, NIBP, non-invasive blood pressure monitoring, mandatory monitor, and your temperature, a mandatory monitor. Got my point? So oxygen saturation, this is also oxygen saturation waveform, mandatory monitor. So these are our mandatory monitor. Mandatory means you have to attach it to everyone. Everyone, you have to attach the monitor. Mandatory monitors, must. Okay, got my point? Okay. Now, apart from these mandatory monitors, there are some important desirable monitor, which I will tell you. But before that, just see some important waveform for CAPNO. CAPNO waveform, very commonly asked in exam. This is a normal CAPNO waveform, right? This is dead space plus alveolar, only alveolar, and then inspiration. So these 3 represents expiration, and this represents inspiration. So in CAPNO, we have a CO2 graph against time, carbon dioxide graph against time, and every breath is every breath is demonstrated on CAPNO. CO2 comes from expired air. Dead space doesn't have CO2, flat line. Dead space plus alveolar, CO2 increases, then only alveolar, and during inspiration it will touch the baseline. This is normal. This is abnormal. The second graph. This is a graph of CAPNO. This is called shark fin pattern. Shark fin. Well, when the group of sharks swims their fin above the surface of water, this is seen in bronchospasm, partial obstruction. Bronchospasm, any obstruction, any foreign body, any obstruction, shark fin pattern. Then increasing EtCO2. It can be seen when the CO2 is retained in blood. That is hypoventilation. Or when CO2 is being produced in high amount. That is in hypermetabolism. So in hypoventilation, hypoventilation and hypermetabolism. Okay, it can be seen. Hypoventilation, hypermetabolism. Okay, decreased CO2 can be seen in hyperventilation when CO2 is less in the blood, hyperventilation, or in hypometabolism. So when CO2 is decreased. So this is normal graph I told you, and normal value is also written here, 35 to 45. So if the value increases, it can be due to hypoventilation or hypermetabolism. And if value decreases, it can be due to hyperventilation or hypometabolism. Okay. Then rebreathing. If in inspiratory gas also carbon dioxide is there, the baseline will get elevated. Inspiratory gas will not touch the baseline. So this is the graph of rebreathing carbon dioxide. Then this QRA cleft. This cleft comes in normal graph. This means return of spontaneous ventilation. Patient has started breathing on their own. Then if I get a flat line, nothing, patient is in cardiac arrest, possibility of cardiac arrest. And if I am doing CPR and the waveform returns, this means return of spontaneous circulation. All these are important waveforms of CAPNO, important waveform of CAPNO 2 for exam, okay, which can be asked. Any waveform can be asked. Then I told you, these are 5 mandatory monitor, right? These are 5 mandatory monitor. Apart from this, for a patient under GA, there are 2 desirable monitor, desirable. What are the 2 desirable monitor? The image can be asked. This is a BIS monitor, bispectral index. BIS monitor. This monitors depth of anesthesia. Depth of anesthesia. Got it? So this monitors depth of anesthesia. Remember, guys. So patient under GA, we have to keep adequate depth. This is a good monitor, depth of anesthesia. So this is a desirable under GA. Every patient under GA, please attach it. Desirable monitor. Then this is something called neuromuscular monitoring. Very commonly asked in exam. Another desirable monitor. Neuromuscular monitoring. This is another desirable monitor for a patient under GA. So under general anesthesia, this is another desirable monitor. What we do? We monitor one of the nerve and a muscle to see whether the neuromuscular blockade is adequate or not. Most common nerve, very commonly asked in exam, most common nerve, which is monitored by neuromuscular monitoring, ulnar nerve. So this is very popular question. Image was given in one of the last exam and they asked which nerve is being monitored, ulnar nerve. So again, a probable question. So ulnar nerve is the commonest nerve. And this is the neuromuscular monitor. This monitors the neuromuscular blockade. It's a desirable monitor. Please attach it to a patient under general anesthesia. Okay. These are the probable questions which can be asked on monitoring. Then a very important question which can be asked is on basic life support. Basic life support, right? In basic life support, sequence is very important. What is the sequence of managing a patient in cardiac arrest? First is scene safety. Scene safety. Call for help. Call for help. Third is look for pulse and breathing. Look for pulse and breathing. No pulse, no breathing. Start high quality chest compression. High quality chest compression, right? Start high quality chest compression. So we start with compression and 30 compression to ventilation. We do this till AED arrives. AED arrives, automated external defibrillator, AED. AED, whenever AED comes, attach immediately. AED attach immediately. Immediately you have to attach. Once AED is attached, it will give 2 things, shockable rhythm or non-shockable rhythm. And if it is shockable rhythm, we give shock and continue compression ventilation. Non-shockable, compression and ventilation continued. Okay, we go on doing this. So guys, what are the important questions? Sequence. Second thing, when is AED attached? As soon as it arrives. What are the points for high quality chest compression? Push hard. That is at least 5 centimeter. Push fast, 100 to 120 compression per minute. Allow complete recoil. Minimum interruption in chest compression and just adequate ventilation. These are the 5 points for high quality chest compression. Got my point? So remember this, high quality chest compression, high quality chest compression. Okay, so this is this is basic life support. We go on doing this till the advanced cardiac life support teams takes over. ACLS, advanced cardiac life support teams takes over. And what does it do? ECG attached. And when each ECG is attached, there is a possibility of four rhythm of cardiac arrest. First one is ventricular fibrillation, right? Second one is pulseless ventricular tachycardia. Both these comes under shockable rhythm. Right? So shockable rhythm, what is the definitive management? Shock. We have to give shock. We have to defibrillate the heart. And two other rhythm is your asystole, which is a straight line, and pulseless electrical activity, which can be any electrical activity which is not VF or VT or straight line, but there is no pulse. But no, on the let's say monitor, it is not VF, it is not VT, and it is not a straight line. Then it is pulseless electrical activity. And these two are non-shockable rhythm. And non-shockable rhythm, what is the management? CPR, that is compression and ventilation. This is what we do. Got my point? Compression and ventilation, and find the cause and then try to reverse. So any question asked, they tell you the patient is in cardiac arrest. How would you manage? And they show this is the rhythm. If it is VF, then what is the definitive management? Defibrillation, shock. We give 200 joules of asynchronized shock. If it is VT, shock. These are shockable rhythm. These two are shockable rhythm. If it is straight line asystole, compression and ventilation. If it is pulseless electrical activity, compression and ventilation. Got my point? So this we have to remember. And what are the emergency drugs which we can give? We can give adrenaline and amiodarone. These are the two emergency drugs, adrenaline, amiodarone. Not atropine. Atropine is not an emergency drug for cardiac arrest management. Adrenaline and amiodarone. Adrenaline, what is the dose of cardiac arrest? 10 ml, 0.1 milligram, 1 in 10,000. This is what we have to remember. 1 milligram, 1 in 1,000 is diluted to 10 ml. 10 ml, 0.1 milligram, it becomes 1 in 10,000. Whole 10 ml we have to give. And we repeat every 3 to 5 minutes. Okay. And this is used in both shockable and non-shockable. In both kind of cardiac arrest, shockable and non-shockable cardiac arrest, right? Amiodarone, 2 dose only. First, 300 milligram IV bolus. Second, 150 milligram IV bolus. Only 2 dose. Right? Only in shockable rhythm, not in non-shockable. Only in shockable rhythm. So amiodarone can only be given in shockable rhythm. That is ventricular fibrillation and pulseless ventricular tachycardia. And adrenaline is given in both shockable and non-shockable rhythm. Amiodarone only 2 doses. Adrenaline, no upper limit, every 3 to 5 minutes. Okay. And remember, shock also doesn't have upper limit. Every 2 minutes, if it is still a shockable rhythm, we give a shock. Got it? So this is the management of ACLS, advanced cardiac life support. This is very important for exam questions. Now, all this which I discussed with you very quickly was a quick review of all the topics of anesthesia. That was quick review of all the topics of anesthesia. From all topics, the most expected questions I have, let's say I have points I have taken out, right? Which has been asked in last 4 or 5 years, right? These are the last few revision points which you have to remember before going for your exam. And my best wishes for your exam. Give your exams nicely and join us in your preparation with Alan Next, right? So join us with Alan Next. We are your faculty, and in your last lab, we will be there with our YouTube sessions also. And even we are coming in full-fledged way with both online and offline classes. So I hope you have enjoyed the lecture. Thank you so much for your patient listening. Thank you, guys. Any question you can ask? Okay, so thank you.